Alright, I'm going to finish off Chapter 7. Uh, the video stopped at slide 26. All the other students left because we had already finished up. But there's reasons for growth for outpatient care, primary care. And part of it is, or a lot of it is, to changes in reimbursement. There's constraining inpatient services. So if you remember, we talked about demand side rationing for services, and one of the ways to do that is if you constrain payment, if you restrict payment for inpatient services, and individuals want to continue to provide the services, they'll move it to outpatient. So if insurance companies reduce the reimbursement on the inpatient side, there's a natural movement of providing the services to outpatient. So that's one big reason. Another big reason is people just prefer outpatient services, and even physicians prefer outpatient services in some way. It's just easier to get the job done. And in general, for outpatient primary care services, there's less restrictions outside the hospital, less regulations, things like that. So surgery, dialysis, chemotherapy, things like that can be provided in facilities that carry less regulations, rules, credentialing, things like that than a whole hospital. So that's an incentive there. And then also outpatient is considered paid for as fee-for-service as opposed to bundled payment and things like that. So physicians and providers can be paid on a service-by-service basis, which is advantageous. There's a development of new technology. As technologies get more advanced, there's a natural push for those services to be provided in outpatient because it's a simpler, less regulated area, and it's more convenient. And candidly, these people stay healthier if they are outside the hospital in general. And there's quicker recuperation as people are recuperating from surgeries more quickly. They don't have to spend the night in a hospital before they go home. Managed care restricts utilization, which then promotes quicker discharge. So, for example, pre-authorization for surgery and with DRG or bundled payments, a hospital or an organization is only going to get a one set fee for whatever the procedure is. So, and they may only authorize a certain amount of perhaps days in the hospital if they're going to do it, or even certain things related to a procedure, which then pushes it toward outpatient services, if that makes sense. So the hospital is one of the most expensive areas to provide healthcare services. In general, insurance companies or managed care companies want to spend as little as possible on the provision of services. So restricting the number of days and time someone spends in the hospital will lower the cost for that service to the insurance company and to the patient as well. So again, that's a natural push to restrict services on the inpatient side. Excuse me. Utilization review. It's found that less services and less consumption happens outside the hospital. So managed care organizations provide, they say they provide, but really they're doing oversight and utilization review, oversight, monitoring not only your facility but a bunch of facilities as to the best way or the most economical way to control the use of resources through utilization review. Social factors. In general, people don't really like hospitals and they prefer to go to outpatient. It's also usually closer to home and more convenient and more cost effective. So social factors do that as well. I'm on slide 28 now. In general, outpatient services. In general, they're diagnostic in an initial assessments and diagnoses. That's a big reason to see someone outpatient. Episodic care for common non-chronic illnesses and injuries. So maybe stitches, or in class we were talking about getting a wart burned off, or some other procedure that a primary care provider could take care of. Is done on an outpatient basis. Excuse me, sorry about that, I don't mean to yawn. I guess it's not only primary care, but specialists like doing outpatient stuff too. It's more convenient. Going in to get a prescription for drugs to treat common illness or injuries, so maybe muscle relaxers or something like that is something that can be used, or it can be received on an outpatient basis. Routine dental care is considered outpatient. For a number of years, dental service providers have been trying to convince, lobby, cajole the powers that be to treat dentistry like primary care in general. Many people see a dentist at least twice a year, and they get to see, the dentist then gets to see the patient even more than a primary care doc does, and you can tell a lot by someone's dentition, health, general health and things like that, by looking at their gums and looking at their teeth, things like that. Physical and mental health conditions usually require referral, although some primary outpatient care will give an individual antidepressants for a period of time. On slide 29, private practices versus group practices. There's a shift from independent solo practice to group practice and institutional employment. Primary care physicians are more often employed by hospitals and hospital groups these days, and there are fewer and fewer independent solo practitioners. One doc serving out of one office is getting very, very rare. Why, do you ask? Well, there's lower operating costs overall, or per doc, if they group their services. So there's strength in numbers and efficiencies in numbers, so they can share startup costs and overhead and equipment and diagnostics. There's also a greater opportunity to contract with managed care or insurance companies when you're part of a group. Insurance companies like it easy, and if they can use one contract to get the services of many physicians, they prefer to do that than having to get separate contracts for many separate physicians. So that's another incentive. For patients, patients generally like group practices better than individual practices because they can get more services in the one location. So think about it. If you're a primary care outpatient group, you might have your pediatrician, your internist, your family medicine doc, your OBGYN, and your geriatrician all in one group, which then covers all the stages of life for a given family or a physician, or a given family or a given group. And that's considered advantageous because you can get all your routine services in one stop for the whole family. Now, some outpatient groups will then add some of the very popular specialties like dermatology, maybe cardiology, maybe orthopedics, because it's very common to have injuries in areas that those physicians can provide service, and they can do that on an outpatient basis. So there are 5 main types of outpatient services. There's clinical services, which would be physician or specialist consultation. There's surgical services, and then there's emergency services for acute situations. So that would be like your ER, your urgent care, maybe your non-urgent care, like a minute clinic or something like that. There's home health care, which is outpatient or ambulatory, considered outpatient or ambulatory, and then women's health centers. Women are major users of healthcare, just in general. Women's health has become a national priority. They are, in general, the majority, most care, at least in a family, is directed by if there's a female head. So it just makes sense. Plus, we want to keep women healthy. Some freestanding outpatient clinics. You have your walk-in clinics or your ambulatory care, which can be ambulatory care all the way to through primary, basic to urgent care. There's so those are generally used for non-routine or episodic things. So let's say you're feeling really, really sick, and maybe it's 9 o'clock at night. Your primary care doctor's office is not open, so you might go to the Minute Clinic at Walgreens or an urgent care. Your intention generally isn't to start up a long-term relationship with them. You just want to get some services and then go home. So that's what walk-in clinics are for, and they're meant to be very convenient. Urgent centers or urgent care centers are usually open 24 hours, 7 days a week, and they offer a whole bunch of different services. It's not emergency. It doesn't have to be emergency stuff. It's just a place where people can get service at off hours. In general, it's first come, first serve. You don't make appointments, and it's definitely not an emergency department. Surgery centers are freestanding places where you can get surgery. It's kind of self-explanatory in the name. They can be part of a hospital system, but they don't have to be. They can be owned and operated by independent physicians. Full range of services for surgeries, and there's no overnight stay. There's also mobile medical diagnostic and screening services. You've probably seen those, where you have your mobile x-ray truck or mobile mammography truck or something like that. And the whole goal behind that is to transfer the service or get the service closer to the patient in their neighborhood or place of work or something like that. Other examples, eye care, mobile dentists, mobile diagnostics, which we talked about. Other outpatient services include home health, so any service that's brought into your home. Can be nursing or medication management, bathing, other activities of daily life, homemaker services, durable medical equipment, which a piece of durable medical equipment would be something like a wheelchair, oxygen, beds, walkers, commodes, stuff like that. The alternative to home care is institutionalization or a stay in a hospital. So in general, the outpatient stuff is more popular because people generally don't like going to the hospital. There are a couple of good figures in Chapter 7, 7.7 and 7.8 are figures worth looking at. Hospice is comprehensive service for the terminally ill. In general, it's for people who are going to live 6 months or less. There's 24-hour staffing. There's docs and nurses, social services and supports, not only for the individual but for the family. Because again, the odds are, well, hospice is for folks who have decided not to pursue curative care anymore. So they're just deciding to live out the rest of their life in the most positive way they possibly can. Within hospice, there's 2 areas of emphasis. One is pain management, which is called palliation, and then there's psychosocial and spiritual support, so helping people deal with their final transition from life into death. Other outpatient care services, I'm on slide 37, ambulatory or long-term care service like nursing homes, case management, which the case manager coordinates care for an individual and helps get referrals to other services that they need. They also help the patient figure out what is the most important or appropriate service that they should pursue. There's also adult day care, or adult day health is considered an outpatient service. Other outpatient services, general public health, which which could include immunizations, to just regular preventative or episodic services, like again, immunizations, but it could also be physical therapy or other procedures, things like that. Public and voluntary clinics, I talked a little bit about FQHCs, or federally qualified healthcare centers, which are often referred to as community health centers, and they're funded by the government to provide access to populations that would otherwise have trouble getting to a doctor. Deep inner city areas have these kinds of clinics, as do very, very rural areas, where it'd be difficult to recruit and retain a physician based on the competitive landscape, as far as their earnings potential goes. Free clinics and other clinics are also considered outpatient. Complementary and alternative medicine, if you know anybody that gets acupuncture or energy work or massage, that's all considered outpatient. Telemedicine or telephone service is growing in popularity. It's 2018 right now, and there's some legislation moving forward that will allow people to bill Medicare for some telehealth issues. So that's a pretty big deal. In general, though, the telephone access for anybody provides triage and opinions to the patient, and they really tend to help people when the physician isn't in the office, so like after hours on weekends and stuff like that. It takes us to slide 41, which talks about the Affordable Care Act. In general, under the Affordable Care Act, the expectation is that primary care, specialty care, so all docs basically, and hospital emergency departments are expected to be burdened heavily, because there's going to be a big influx of new patients. We talked about in last chapter 5, that there's, when people gain insurance, they use services. Remember the conversation we had about moral hazard, where moral hazard is the getting services that aren't necessary. Getting services and having the fact that you don't have to pay for them out of pocket plays a heavy role in the decision. So I use myself as an example in class. If I ran into a goalpost and broke my nose, and if I met my deductible for the year and my copay is relatively inexpensive, I might go see a surgeon, a plastic surgeon, to fix my nose that's broken, as opposed to waiting it out until spring or fall or something like that, or perhaps seeking a different method to straighten my nose and promote healing and reduction of swelling. So that's an example. So the Affordable Care Act again increases the use of services, because people that used to not have insurance now have it, and they're insulated from the cost. Under the Affordable Care Act, there's a need for providing uncompensated care by hospitals. The need is going to be there, but the expectation is the need will decrease, that less people will need to have their care be uncompensated. What it doesn't talk about is the fact that hospitals under the Affordable Care Act and the programs that sign up for the Affordable Care Act, or providers or insurance providers associated with it, is that not everybody will get insurance. If you remember from a previous lecture, when the Affordable Care Act came online, a lot of people got coverage, but a lot of people lost coverage too. And that, if they would need service, that would be uncompensated care. So that's expected to be a constant under the Affordable Care Act. Components of the Affordable Care Act will affect community health centers. In general, health centers will be located in states that don't expand Medicaid. Could face fiscal shortfalls. So there was an incentive of, if the federal government wanted states to expand Medicaid, for those states that did not expand Medicaid, funding for their health centers is thought to be at risk. Again, the goal was that everybody would buy in to the Affordable Care Act, but not every provider wanted to. All right, so that's it. That's slide 41 on Chapter 7. I hope you have a good evening.